Hi, I'm Dr. Andrew Nicholls. I'm a general practitioner. I've been a general practitioner for 35 years or more now. About half of that time a rural general practitioner in a place called Yarrawonga on the border between Victoria and New South Wales, and the other half in Melbourne here. I'm a procedural general practitioner, so I've spent a lot of time doing anaesthesia, giving anaesthetics. I've delivered a very large number of babies, done a lot of obstetrics, a lot of emergency medicine, all as part of my procedural general practice work in the country. And nowadays I divide my time between general practice and working as an anaesthetist here in Melbourne. But my primary domain is general practice. And I've been with ARIMGSAS doing a communication, initially doing a workshop on women's health, but then one on my real passion, which is communication skills and consulting skills. I've been doing that for 2 or 3 years now, I guess, because I think it's really important for you people who are trying to pass the AMC Clinical Exam, and possibly even more so for the pesky, but for both though. I've also should mention that I spent 16 years as a clinical examiner for the College of GPs for their fellowship exam, and there are some significant similarities between the fellowship exam for the College of GPs and the pesky and even the AMC Clinical. People go wrong with these exams, and I see it time and time again. People pass the part 1 because that's all about memorising, sort of committing things to memory, rote learning, anticipating previous questions coming up again, things like that. People go wrong because they try and transfer that sort of mentality into the clinical exam, and it just doesn't work. There's some real keys to passing this clinical exam. One of them is you have to be organised and you have to have a system. If I talk about the AMC Clinical, it has a lot of good things about it and some things which I think are quite misplaced. For example, the fact that you're not allowed to have a watch with you for some reason, or a clock. And also it's only 8 minutes, which is very impractical and sort of encourages rapid turnover medicine. So there are some problems with it, but where people go wrong is they're not systematic. They don't have a systematic approach to it. They don't pay enough attention to the time. They miss tasks that they've been asked to address, and they do it like they're talking to an examiner. That's not the way you pass it. You pass this exam by treating it as though you're with a patient. And I cannot stress that strongly enough. If I had to name one area where people go wrong, it's they don't see themselves talking to a patient rather than a role player in the exam setting, whether it's on a video or in person. You must make that adaptation if you want to pass this exam. I feel that strongly about it. I've been telling doctors about that for years, over 20 years, more than that. They want to see what you're like with a patient. That's why it's a clinical exam. They don't want to see you feed back to them a whole lot of templates about how you address this and that other problem and making it all very much like a robot. They don't want to see that. They want to see the human doctor. So I can't stress that enough. I can't stress enough the fact that you need a system. So you need a nice greeting. You need to avoid cliches. Things like, "Hi, I'm your doctor today." Today? Well, what about tomorrow? These sort of things people slip into, and it drives examiners crazy when they hear all these cliches. So a nice greeting in either of the 2 clinical exams, address the presenting problem, flesh it out, And I mention this, I do a workshop, of course, as I said, for the Alan Roberts organisation, and I go through these things in great detail. I don't do this for any gain. I do it because I really enjoy it and I want to pass on my experience. But I would recommend, if anyone hasn't been to my workshop, to attend it if you really want to give yourself a good chance of passing the exam. So you must treat the clinical case like you're a detective. You're solving a case. You're solving this problem. So you have to use the mightiest GP of them all, Dr. John Murtagh, as your skeleton and the way you approach it. And you solve the case. You start by ruling in or out the serious disorders not to be missed. Then you move on to the common presentations that it could be. You keep in mind things like pitfalls and the masquerades that John Murtagh talks about. When you've done all that and you're bearing in mind the time ticking by, you then perhaps you might do a relevant systems review. And very importantly, you do what I call a sad mal. Some people call it sad ma. I call it sad mal. You must do the whole thing. I see people all the time, they just do a bit of it and they, Murphy's Law, they miss out the bit that's relevant. You ask about smoking, alcohol and recreational drugs, and be careful with your language. That's what I try and tell you about in my workshop. Don't say things like illicit drugs. You're virtually saying, are you a criminal? You use things like recreational drugs. So do you smoke, drink alcohol, usually recreational drugs? Even if it's a 90-year-old lady, they won't get offended in Australia. And then medications, sad mal. So medications, what medications do you take? You must find that out even in an 8-minute clinical exam. And are you allergic to anything? And the O is the other histories. And you bang through them and they are important. So with the other histories, do you have any past medical, surgical history? In other words, have you been into hospital for anything at all? What about history, medical history in your family, your parents, brothers and sisters? And help them. Anything like heart disease, diabetes, high blood pressure, strokes, cancer, things like that. Help them with that. Then don't forget, just quickly, what work do you do if that's appropriate, and who's at home with you? Because that'll give you the clue. Now, who's at home with you, you might get a little bit of a clue there that things are not too good at home. And it might be a case about domestic abuse or something like that. And then you've got to remember the time going by. When it comes to the physical examination, you start from the global and you go to the specific and the focused. So obviously your physical examination, you keep it real. You see a real patient in front of your eyes. You see yourself in a consulting room or a hospital emergency department, whatever the scenario is, that's where you are. You're not sitting on a chair talking to someone on a video. You see the patient, you then assess them as they move from where they've been sitting to the examination couch. You might have a few templates in your mind, wipe and things like this people use. Don't mention them by name. Just do them or explain what you would do. I'm going to wash my hands. I'll explain what I'm going to do. I'm going to make sure the patient's comfortable and understands what examination I'm going to do. Things like that. Then you do vital signs. Avoid jargon. Don't say the vitals. And don't say I'm going to take... You've got to think about what you say. Don't just say it because people in your study group say it. So don't say I'm going to take the blood pressure in 2 positions. What does that mean? You're going to give the patient a stand on their head for one of the positions? I'm going to take it lying and standing. Don't say cliches. Think about what you're saying. Always with doing the heart rate, I'm going to check the heart rate and regularity. Always. Well, you'll miss the atrial fibrillation one, won't you? Then you go from the head down and you keep it relevant. Head, neck, trunk, pelvis, limbs, thinking of neuro and orthopedic, but keep it relevant. And then don't forget your office tests. And the whole time you're thinking about the time that's elapsed. Because so many people fail because they haven't finished, they didn't do all the tasks. So you're not going to pass. Differential diagnoses when it comes to that. The AMC Clinical, they do like a lot of diagnoses, and that's good. Because what they're trying to weed out is people who make up their mind in 20 seconds what's wrong. Those doctors are very dangerous. So they want you to see that you've approached it from a broad perspective, the problem. They want you to say what to diagnose. If they ask for diagnoses, if they say, what is your provisional diagnosis, you give one. If they say diagnoses, you give maybe 6 or more. Start with the most likely and why you think it is. Then mention the serious ones that you've ruled out, and then the other common ones. With a management interview I think is generally done very poorly, and I think that's probably lack of experience, clinical experience. So again, you have to be with a real patient. You have to have that real patient with you. Think logically, don't say a test that you can't justify, whether it be a blood test or imaging, and be comprehensive. If it's a clinical case, do things like you would in consulting rooms. I'm pretending to type. I'm going to get the reception staff to book your chest x-ray for this afternoon, because I'm a bit concerned, and I'm going to get them an appointment to see you tomorrow. That might be an appropriate thing for you to do as part of your management, to follow things through. And avoid cliches, or what they call euphemisms. Don't they say things like a nasty growth. I've been telling doctors not to say that for 6 years. There's a very good document you should all read that came out, I think, on the 4th of October from the AMC about what they're looking for in the AMC Clinical Exam. And they specifically mention that one about nasty growth. Get that out of your vocab forever and ever. You don't say that to a patient. These are the sort of things I'll talk about, as well as what I'm very big on too, which is the fact that we need to be empathic, communicative doctors in an Australian setting. Australia's an informal country. Patients seeing a doctor in Australia love humour. They love informality. It's an equal relationship. Some cultures it's like this. We try and make it not like that. It's like that, a partnership. So they're the sort of things that I think are really important. And as I say, do yourselves a favour, as they say. If you want to give yourself a better chance of passing, tie the whole thing together with how you go about doing the clinical exam. Not just learning all about obstetrics, gynae, this and that. It's how you do the exam. And be careful, I'd say, about who you choose as your practice partners. Because another thing I'm fond of saying to doctors is, there's a saying, practice makes perfect. It's completely wrong. Practice makes permanent. So if you practice the wrong thing all the time with other doctors who don't know what they're talking about, you won't improve. Perfect practice makes perfect. Anyway, that might be enough for me to say, because I just really want to explain what I bring to a workshop, and to say things that help you to pass the exam and to be a good doctor in the Australian context, and a safe one.